to the series named Fertilogix. This evening, with all our coveted organizers and speakers that we have shared with the doctors who are registered online with us who are hearing to this webinar. This is the first very chapter, first very session where I, Pallavi More, get a chance to welcome all of the doctors who are, of course, a part of the faculty members who represent Fertilogix and all the doctors the delegates who are attending and listening to this session astutely to learn many newer aspects of infertility or related to infertility practice with IVF techniques. Fertilogix is a really renowned, represents a renowned name because it is a collaboration of ISAR Madhya Pradesh team, Madhya Pradesh chapter, along with an organization which is at its epitome in nutraceutical business, UNS. UNS holds a legacy of almost 3 decades, which is 30 years in India, representing pioneer brands coenzyme Q10, which was first introduced in India by Universal, today is creatively and popularly known as UNS in the hearts of all the doctors across India. Yes, UNS also carries a legacy of trusted brand, not just CoQ, but Primoza, Ecod Omega, and many other brands that the doctors resonate and will recollect and have a very strong recall with. This organization has a very strong leadership on its back end, and you can see some of our team members are also present on this call, helping us reach the science to the doctors. Science is the key when it comes to UNS, and of course, which is why we tie up with the leading practitioners, the leading gynecologists, the leading IVF experts of the country to disseminate this science. We don't believe in keeping the science to us, we believe in disseminating. And which is why this is the first session where we begin with Fertilogix, the logic that can be placed in the practice of IVF to make it even more resounding and helping the patients achieving their outcomes. I got this opportunity to start this webinar first series with Dr. Archana Bashir herself, and a big thank you for supporting and initiating and being the guiding force behind the Fertilogix series. I also would like to welcome our chief guest in this evening, Dr. Fagun Shah, with us. Thank you so much, sir, for being, and also the guest of honor, Dr. Chaitanya Nagori, sir, and Dr. Alpesh Gandhi, sir. Thank you so much for being a part of this program and honoring this particular event online. There are valuable chairpersons who are also present, Dr. Sunil Shah, Dr. Hitendra Somani, Dr. Sanjay Desai, and Dr. Kokila Desai. And of course, our key speakers will be introduced by the medical team and the faculty present over here. Thank you so much. And with this, I will hand over the session to our medical director, Dr. Manish Garg. Over to you, Manish, sir. Thank you so much.
Thanks a lot, Pallavi. So this is Dr. Manish from Universal NutriScience. I'm the head medical and regulatory affairs. At the outset, would like to thank Dr. Archana Basir ma'am for helping us partner with her chapter, ISAR Madhya Pradesh chapter, for this series of Fertilogix. Just to give a background, Fertilogix, the word originates from a fusion of two words, fertility and logics, symbolizing a smart and science-driven approach to fertility treatments. So Fertilogix, this is the first in this series, and the theme is Advancing IVF Personalized Fertility Strategies. Thanks to Madam, we have coordinated with her team, Dr. Kalyani ma'am, as well as Dr. Rudri Agrawal ma'am. Dr. Kalyani ma'am, just to give a brief intro about ma'am, she is a clinical director and senior consultant at Nova IVF. She has a rich experience, a rich expertise, performed more than 6,000 procedures, several awards and professional affiliations. And in fact, she is one of the reviewers for publications in the journals of Obs and Gynecs. So I think those who are looking for publication should reach out to her. Dr. Rudri Agrawal, ma'am, she is expert in reproductive medicine and cosmetic gynecology, studied with gold medals throughout her career, whether it's in MBBS or her MS, studied with gold medals, several awards to her credit, and also great medical writing skills, whether it's books or chapters in the books. Member of several committee. With this brief intro, I'll pass it on to Rudri ma'am for further proceedings. Ma'am, over to you.
Thank you so much, Manishji, for the kind introduction. Let me proceed the event further. So, good evening, one and all, and a cordial welcome to the collaborative webinar series of MP chapter of ISAR in association with Gujarat. Very beautifully explained by Manishji that it is titled as Fertilogix. So, let's learn and explore the logics behind fertility. It's indeed my pleasure to host this event today because today we are having some of the stalwarts of the field and very eminent speakers amongst us from Gujarat. I'm highly grateful to all the faculties who have accepted our invitation to join us and took out their time from their busy schedules. So, without further delay, I'll kickstart the event and I'll request my technical team to play the lamp lightning video because before that we can't proceed. So, let's seek the choices blessings of the God. May I have the video, please?
Sure, ma'am. I'll play it.
I think Dr. Manish will going to play it, ma'am.
Just a minute. I'll play.
या कुन्देन्दु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणा पुस्तकधारिणीम् अभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम् या
Thank you so much, UNS team, for coordinating the event in a very much collaborative manner. Now, let me request my most favorite senior, I should say, Dr. Kalyani ma'am, to take the session further and introduce Baser ma'am and to take the session further. Thank you so much.
Thank you so much, Dr. Rudri, for the kind introduction. Can we have the screen with all the CVs? Till we have all the CVs up on the screen, I would really like to thank Dr. Baser ma'am for giving us this opportunity to conduct today's program. And this is just the first and the beginning of the program known as a Fertilogix. Thank you, UNS, for hosting this program. And we are looking forward to more and more of the CMEs eventually in all the coming months. So as decided, I think we'll be going ahead with every third Wednesday of the month with a series of the CMEs along with the MPSR and under the guided able of Dr. Baser ma'am that will be moving forward with the multiple CMEs in the coming months. So without further delay, let me introduce Dr. Baser. So we all know Dr. Baser ma'am. We as the juniors, we have a lot of respect for Baser ma'am. You all who have accepted the invitation as her friends and her beloved well-wishers. We all know everything about Dr. Archana Baser, but still, as the protocol goes, I need to introduce her. So Dr. Baser ma'am, she is the consultant obstetrician and gynecologist and director at the Akash Hospital in Indore. She is a past vice president Foxy 2020 for the West Zone. She was also an organizing secretary for AICOG 2021 in Indore. She is a fellow representative for AICC-RCOG West Zone, Imaging Science Committee Chair, Suffolk, and of course, she has been one of the Guinness World Record holder for removing the largest of the uterine tumor. In the past position, she has been the chairperson for Foxy Imaging Science Committee 2015 to 2017, organizing secretary ISA 2016, and managing committee member for ISA 2018-20, IAGA 2018, and ICOG 2017-19. With a warm welcome, Dr. Basair ma'am. Would you be able to, ma'am, please introduce the guest of honor for today, Dr. Chaitanya Nagori sir and Dr. Alpesh Ramdi sir?
Hi, good evening, everyone. It gives, delighted to welcome all of you on this platform as a chairperson of MPSR in collaboration with UNS. First of all, I would like to really, before I give introduction, thank my team, Dr. Kalyani and Dr. Rudri, for really, bringing all the pearls of, IVF infertility and from the Ahmedabad and around. So thanks to them. And let me introduce chief guest and guest of honor. So may I have the CV of Dr. Fargun Shah, Dr. Nagori in what? Yeah. So Dr. Fargun Shah, he's a private practitioner at Ahmedabad. I have known him since long. I think 2013 when he was secretary of Ahmedabad Society and Dr. Mahesh Gupta was president, I was invited to give a talk on ultrasound. And since then, we have been meeting in Foxy conferences and different meetings. And he is a very, very enthusiastic obstetrician and gynecologist. His main interest is in field of endocrinology and newer molecule and new drug delivery system. He has been invited as guest faculty at national and international conferences. And he loves to trek, meet people, and listen to soft music. And I have seen his, he's organized a very big AICOG conference along with his friend in 2020. So I have seen the managing part of the Dr. Fargun Shah as well. So he's a good practitioner, good manager, good friend, and good academician. So Dr. Fargun Shah, would you just give us some words of wisdom for this Fertilogix series?
At the outset, thank you, Dr. Archana, a very dear friend. And the entire idea about giving us the knowledge sharing, which is the best way to learn, as on a monthly basis, where you can do it sitting in your consulting chambers or rooms at your ease, is something which is going to take a long way. I wish you all the best for this and all the future endeavors that you are into academically as well. And I would, at the same time, love to thank your teammates, Dr. Kalyani and Dr. Rudri as well. Also, from the support of UNS, Pallavi and Dr. Manish and Dr. Shruti, they have been very helpful as far as the keeping up with the protocols and things like that was concerned, which were required for managing this event. Thank you very much for taking up an academic cause, which is a very justifiable cause in today's world where knowledge exchange has to be the key factor. Last but not the least, I would like to show my gratitude towards the guests today, all the eminent speakers and delegates, of course, specifically to a dear friend, Dr. Alpesh, and with great and humble submission, I would say that Dr. Nagori has been my mentor, my teacher, and whatever little that I have achieved in the field of endocrinology is 100% from my heart. And sir, I'm thanking you for all what you have done, taught, and still today when we meet, it's a lot of academic exchange. I wish this program a lot of success. Congratulations, Dr. Archana, for all your future activities as well. Thank you very much. I won't waste much of the time. Thank you all.
Thank you. Thank you, Dr. Fargun Shah. Thank you for your kind words. And now I would like to invite and introduce my favorite teacher, friend, guide, philosopher, and he's a teacher of teacher to many. And Dr. Chaitanya Nagori, I think any of my workshops, even whether it was a small workshop or it was a RCOG conference or any conference, if Dr. Nagori is available, he would never say no to me. And he is a great academician. I think whosoever goes to him, I can read his CV, like he got the best paper awards. He has a first stem cell pregnancy in India, first ever center of excellence for Ian Donald School of Ultrasound, training regular in IVF, ultrasound, and he holds a Gujarat University recognized fellowship program in IVF, many journals and many papers. Let me tell you, he is worshipped like a god in our clinic also, because my daughter, I have learned, and many of my colleagues who has been to their center, they say, Sir and Madam Sonal, they will reach dot at 9 if the program is going to start at 9. So, sir, heads off to you for your sincerity and your teaching passion. I think we are really honored to have you as our guest of honor today on this program. So I would like to hear a few words of wisdom, how we can really be not exactly like you, but how we can also impart the teaching.
Highly obliged to Fagun. He has lifted me up, but he's always in my heart. Madam, I'm also thankful to you for appreciating me. Uh, I'm sure that teaching is also your passion, and that's why we always love to meet the teachers. So I'm always very happy whenever you invite us for any academic program, because your programs are always full of academics. So I'm thankful, highly obliged. I wish all the brilliant success for the next coming programs also. And whenever you need my help, I'm always available to you. So thank you very much for your team who has worked very hard, and I'll be always available to you whenever you need. So do a good such academic activities. I think I'll be very happy, because it's a time to make the people aware about the subject. Unfortunately, there is a scarcity of teachers all over India, and I think these are the best methods of teaching the students through various. You can take the help of all the teachers of all over India, and you can make the students learn the things.
You are doing a great task.
So great things you are doing. I'm really appreciating you a lot. Thank you.
Thank you, Dr. Nagori. I remember that whiteboard where you write the names of the patient. I mean, I've been to your center, and it's really amazing center and amazing teaching place. And thank you for your blessings to our program. And is Dr. Alpesh Gandhi here? Has he joined? But I can read his CV. Alpesh Gandhi, it was, like the man who really helped us connect during the COVID time. He was our president. I was vice president under Alpesh Gandhi. And we thought, what are we going to do in COVID times? Because how we will connect with our fellow Foxians. But he came up with this beautiful idea of webinars. And without traveling, we could connect with many. When he is Foxy representative to AOFOG, national convener of HRP, then he is Gestosis India president. He has been conferred with RCOG from by RCOG, FRCOG, awarded with Abdul Kalam Living Legend Award. And he is awarded total 57 orations to his credit. And his chapter is in the textbook of FIGO. He has organized one of the most successful AICOG 2017. I think we all know Dr. Alpesh Gandhi as a big, like an excellent president, Foxy, very good academician, and very simple, down-to-earth person. If he's not there, I'll just pass the message to him, sir. We missed you on the program, and we would have your, blessings again, maybe at the end, if you can join, or at a later date. And I would like to, before I wind up from this, I would like to really appreciate our speakers, Dr. Amin, Dr. Bhavishi, and all our panelists who has joined, and the chairpersons, experts, Dr. Sejal Naik, Dr. Desai, everyone who has really spared time and come here. So I think we start with the scientific session now. Dr. Kalyani, I think Dr. Alpesh has sent some message. He got busy with emergency. He will join when he is free, so we'll take his blessings when he comes. Yeah. So over to you, Dr. Kalyani.
Yeah. Thank you so much. So now we begin with our scientific session for today. And we are going to cover today's CME with two speakers with the topic of IVF pregnancy, are they different, and the low AMH, followed by a panel discussion So first of all, I would like to invite all our chairpersons to chair the session for the two lectures that we have. So I would like to invite Dr. Sunil Shah, sir. He's a senior IVF consultant in Ahmedabad, and he has been the joint secretary of FOXY 2020 and past president of Ahmedabad Obs and Gynae Society. Welcome, sir. Dr. Hitendra Somani, he's the senior ART practitioner in Bhavnagar, and he's also the chapter secretary for IFS Gujarat. So welcome, Dr. Hitendra. And Dr. Hitendra is also a very good friend of mine. We have been together since, I think, almost 15, 16 years. We were together doing a fellowship in Germany. So welcome, Dr. Hitendra. It's very, very nice to see you out here. Can I have the next slide, please? Dr. Sanjay Desai, sir. He's the eminent ART practitioner and the center head at Nova Wings Rajkot. He also owns Payal Maternity Hospital, and he has got multiple achievements through his dynamic career, conducted more than 50,000 deliveries and more than 18,000 surgeries. Welcome, sir. Next, please. Dr. Kokila Desai, ma'am. She's the president of Surat OBGY Society and the senior ART practitioner at Shivani IVF Surat. To her credit, she has got multiple publications and awards. And she was also been involved in a lot of organizing, like organizing chairperson for IFS Gujarat Conference 23, State Conference IFS Gujarat Chapter, organizing secretary for Fertilization 24 National Conference, and also the National Quiz Committee West Zone IFS India. Welcome, ma'am. The first topic for today is IVF pregnancy. Are they different? And we have our own Dr. Archana Basai, ma'am, speaking on the same. Ma'am, giving the mic and the stage to you.
Thank you, Kalyani. I think let's start with our scientific session, and I hope my screen is visible, right? So, topic which we are going to be really covering today is about IVF pregnancy. What I am talking is IVF pregnancies, are they different? And Dr. Bhavish is taking how to really optimize the IVF pregnancy rate in IVF, and Dr. Jayesh Amin is going to be taking the low AMH, where do we stand? So our IVF pregnancy is really different. Why are we really worried about the IVF pregnancies? Are they different? I think assisted conceptions are at increased risk of maternal and fetal complications, but it's not clear whether this is a consequence of the ART procedure or of the innate characteristics of women who undertake them. So just a roadmap of my talk. I will be taking you through incidence of maternal problems in IVF pregnancies, identifying high risk amongst IVF group, management, case scenarios, PIH, fetal problems like FGR, preterm congenital malformation, and take to work points. What are the maternal complications in ART pregnancies? First and foremost, ovarian hyperstimulation syndrome, miscarriage, ectopic pregnancy, pregnancy-induced hypertension, preeclampsia, gestational diabetes, venous thromboembolism, and there are placental complications are also known. The fetal complications associated with ART, genetic and chromosomal disorders, structural abnormalities, growth restriction, stillbirth, preterm labor, and multiple pregnancy and related complications. Let's first take OHSS. Like following conventional IVF, mild OHSS has been estimated to affect around 1/3 of cycles. And while the combined incidence of moderate or severe OHSS varies from 3.1 to 8%, there is some evidence to suggest an increased risk of pregnancy-induced hypertension and preterm labor in pregnancies which are get complicated by severe OHSS. Miscarriage in IVF pregnancies rates are almost estimated to be 15 to 20%. And the specific cause of subfertility may also affect the miscarriage rate, like women with certain congenital uterine anomalies, fibroids, and some endocrine disorders. Women who miscarry following ART can generally be reassured that they are more likely to have a live birth in subsequent cycle than if they had never conceived. So that's a little bit of reassuring to women who are miscarried and in spite of having an IVF cycle. Add-ons and pharmacological intervention to support pregnancy in ART. There are several add-ons: heparin, HCG, progesterone, GCSF, immunotherapy, and steroids. But there are evidence that it benefits. There are limited evidence, and recently, I think yesterday only, I came across an article where they say that add-ons don't do much good, but I mean, we all are using it, and they are of some are of really good value. Ectopic pregnancy, there is a risk of ectopic pregnancy following ART, which is approximately 1.4%. Heterotropic pregnancy are also more common following ART, and this must be considered as a differential diagnosis when a patient present with symptoms of an ectopic pregnancy and 2 embryos were transferred. Careful ultrasound examination of the adenoid is required even in the presence of an intrauterine pregnancy. That's the key point which I want to tell you here. Pregnancy-induced hypertension. The pregnancy resulting from ART may have increased risk of maternal medical complications, especially PIH, preeclampsia, GDM, and venous thromboembolism. The risk largely arise due to characteristic of those undergoing ART and are most marked in older women aged more than 35 years, women with a high body mass index more than 30 kilogram per square meter or PCO, and in multiple pregnancies. Pregnancies from oocyte, sperm, or embryo donations are at increased risk of PIH. That has to be taken note of. What are the preventive measures? If we are saying that PIH is more common in pregnancies conceived with IVF, the absolute increase in the risk of hypertensive complication was approximately 2%. And those considered to be at high risk of PIH or preeclampsia should be offered low-dose aspirin 75 milligram from 12 weeks of gestation until delivery. High risk for preeclampsia, there are major risk factors: hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disease, diabetes, and chronic hypertension. There are certain women who have moderate risk factors like post-pregnancy, maternal age more than 40 years, and pregnancy interval more than 10 years, or BMI more than 35 kilogram per square meter, and family history of preeclampsia, and so on. So how to clinically manage a pregnancy in IVF with preeclampsia? Women with any of these high-risk factors, which we have just listened, irrespective of whether they meet the criteria for prophylaxis, should also have a plan for closer maternal and fetal surveillance. At least every 3 weeks, between 24 and 32 weeks of gestation, increasing to 2 weeks thereafter, we should be monitoring these women, especially those who are at risk of severe preeclampsia. I've just brought a very good case scenario, which recently we dealt with, and how really things could have been different. 35 years of Mrs. KB, BMI 26. She was known case of PCO. Previous 2 failed IVF, 1 with self and 1 with donor cycle. She conceived with ovum donation, and it was a frozen thaw blastocyst transfer. Counseling was done regarding expected problems, keeping in mind all high-risk factors for PIH. Singleton pregnancy going very well till 24 weeks. She was from a nearby town, and the most important thing, she has one relative doctor in family. Mrs. KB stopped coming to follow-up. One afternoon at 28 weeks, she called up developing swelling, advised to come for check-up. She missed her appointment. After 48 hours, she came with full-blown severe preeclampsia. Her urine protein was 3+. Blood pressure was 180 by 120. Swollen feet, hands, and blurring of vision. So our challenges were severe prematurity. She had FGR, severe preeclampsia, impending eclampsia, and bigger challenge, the relatives were not agreeing for delivery. I'm sure many of you must have faced a similar problem, because everybody holds on to the pregnancy till term. Even we want to hold the pregnancy till term, and we want to give a term baby to the couple. But when there are medical problems, severe problems, you really have to pitch in and do a safe delivery. So here comes all the problems. Now, the management we offered multidisciplinary, because she had severe preeclampsia, physician was called in, echo was done, ophthalmologist to see fundus, diagnosed retinal detachment because of edema. All battery of investigations were planned, antihypertensives were started, took a lot of counseling to deliver premature. because of severe preeclampsia, we have told them about the Press syndrome and everything. But anyways, they agreed. Now outcome is cesarean section was done. 1 kg baby girl delivered. She needed ventilatory support. Stayed in NICU for 45 days with every day up and down. You know, we are thinking, I hope she goes home with the baby with so many of trouble she has taken. We discharged home just a few days back. Points I want to highlight here is we had no time to give steroids. I mean, ideal world, you would give a steroid so that the babies, like we all know for the respiratory distress, but here the time we did not give, though because we had good neonatal support, we could sail through. So the point here is, in spite of telling them the risk, in spite of giving them the schedule protocol, sometimes they may not follow, and especially if they have a doctor relative at home who is advising them over the phone without seeing the patient, that becomes a bigger problem in managing any patient, but especially more so in your IVF patient. So things probably would have been different if patient has kept her appointment. PIH could have been picked up early and antihypertensive started and steroids given might have shortened her stay in NICU. We were lucky that she went home with a baby, but there was a quite trouble. So how to manage the problems? Number one, can we prevent problems from happening? Maybe yes, by educating patients, relatives, and caregivers, especially our own fellow colleagues, that IVF pregnancies are different. Initially, even I was used to think when I was not doing IVF that, well, now once you have conceived, though it is an IVF because you have not been able to conceive, now it's an IVF pregnancy, so it's like any other pregnancy. But no, IVF pregnancy, those who are seeking IVF, the characteristic of these women is different. So it's important that we all educate ourselves that these women are at high risk of certain medical problems and they need more frequent monitoring. And if they are present with the problem, we need to talk about the solutions. Again, another problem is gestational diabetes. Whether or not ART increases the risk of GDM is controversial, with some studies reporting an increased risk and others not. The prevalence of GDM is twice as high among women with PCO than among women without PCO. And we should consider offering screening for GDM to women who have been diagnosed as having PCO even before pregnancy and before you are taking up an IVF cycle for them. Venous thromboembolism, again, IVF has been shown to double the risk of VTE during pregnancy. So in the absence of any other risk factors, however, prophylactic anticoagulation with low molecular weight heparin, though it's not required in the absence of any risk factor, but you have to keep looking for such complications. Now, coming to the fetal complications on a regular basis, when we counsel for IVF, we are being asked this question, doctor, will my baby be normal? Over the years, as more pregnancies have occurred and outcomes have been reported, much of this fear has been abated. With confidence, we can counsel now our IVF couples. While some complications are more common in fetuses arising as a consequence of ART, but we have good data and good scientific literature and our own results in hand to counsel the patient, but still this question comes on every day in counseling in IVF. There are fetal genetic and chromosomal disorders and structural abnormalities. There are some studies, but not all, suggest that congenital abnormalities are more common in children conceived following ICSI than standard IVF. Despite the reported 30 to 40% increase incidence of fetal structural anomalies observed in individuals undergoing ART, the absolute risk is still very low. Hence, no additional surveillance is recommended other than a routine anomaly scan undertaken at 18 to 20 weeks of gestation. Now, this is a very important slide that points to be taken in consideration. Women with assisted conception should be offered antenatal screening, such as the first trimester combined test, NT, and maternal serum like biochemistry. A few studies have shown that nuchal translucency measurement may also be affected by the type of conception. It is also worth remembering that if donor eggs are used, the age of donor should be used to calculate the APRA a priori age-related risk, not the age of women undergoing treatment, because this can lead to a very big problem. So it is important. Suppose if you are the IVF person who have done the IVF and patient is not following up with you, or they are from another city and going and getting their treatment done somewhere, you have to mention that the donor, though this is a very confidential thing in IVF, but somewhere in some kind of form, either picking up the phone and communicating with the doctor under whose care this patient is going, that this patient is a donor conceived pregnancy, so that the age of the donor is this much, and that has to be put in the biochemical screening. So a screening test, basically they rely on accurate gestational age to interpret the result of nuchal translucency with maternal serology and maternal age. So it is very, very important that the estimated date of delivery is calculated from date of oocyte retrieval and not the measured crown rump length. So it's very important. And FGR, cause of subfertility, itself may account for more of the variation in birth weight than the mode of conception. Stillbirth, there is some evidence that compared with spontaneous conception, assisted conception are at an increased risk of stillbirth. However, I mean, it's determining to what extent ART procedure themselves are responsible for this is very complex. And there are high rates of ART users in women who have previously experienced a stillbirth, and many of times we don't know the cause of stillbirth. So, I mean, you cannot really correlate that well. So timing and mode of delivery, some clinicians feel that because of the higher stillbirth rates observed in assisted conception, induction of labor at term should be considered. On the one hand, there is little evidence that this practice increases interventions such as emergency cesarean section. Preterm labor, pregnancies conceived following ART are at increased risk of preterm labor, and it is difficult to retrospectively distinguish between spontaneous and iatrogenic cause of preterm labor. Undoubtedly, ART is a significant risk factor for preterm labor. Whether spontaneous or iatrogenic, there is no current evidence to suggest an additional surveillance or intervention or beneficial in reducing rate of preterm labor in this conception. Placental complication, there are certain interesting facts which I found when I was preparing this talk. A recent systematic review and meta-analysis concluded that singleton pregnancy conceived using ART are associated with a significantly high risk of placental anomalies, including placenta previa. Compared with spontaneous conception, there is a higher incidence of clinically significant placenta previa persisting until term in assisted conception, particularly those that have involved the transfer of a blastocyst rather than a cleavage stage embryo. So this is very important line. And assisted conception occurring following transfer of cryopreserved rather than fresh embryo are less likely to be complicated by placenta previa. Vasa previa, again, cord insertion variants, including vasa previa, are more common in assisted conception, and this may account for increased incidence of fetal growth restriction in ART pregnancies. So just to conclude, we are all worried about IVF pregnancy. Whenever a patient conceives, oh, well, good, our patient has conceived. And once the patient conceives, our next worry is hope that she doesn't miscarry, or, she carries her pregnancy to the term. What's important, a worry is important, but we have to have a balanced worry. We can't over worry and make our patient worry more than ourselves. So while most assisted conceptions have a normal course, not all will have a normal course. The elective transfer of a single embryo reduces many risks, but even singleton pregnancies resulting from ART are at increased risk of some maternal and fetal complications. And awareness of this risk is mostly all that is required, and assisted conception should be managed in the same way as spontaneous pregnancies. A thorough risk assessment is imperative since many women undergoing ART have additional risk factors that necessitate increasing monitoring. Still in our country, IVF is considered as a stigma, and not many couple will tell you it is an ART pregnancy. So that puts us at a tight spot. And in history, make a point to ask spontaneous conception or assisted conception. Make a note of high-risk pointers or just put a red flag. Date of embryo transfer is important to be mentioned as calculation for biochemical markers to be based on that, not on CRL, and age of donor to be put in form for biochemical screening. And just to summarize, use of assisted reproductive technology to achieve conception is increasing worldwide. Almost 1 to 5% of babies are born from ART, and majority of resulting pregnancy will have a normal outcome. Assisted conceptions are at increased risk of maternal and fetal complications. As a healthcare professionals involved in antenatal care, and especially for women who are conceived using ART, must understand the potential risk and significance and how best to monitor them. And most important thing, must counsel couple before and during IVF treatment about the potential problems. Don't leave it to the last when the problem comes, so that they are better prepared for the case. So thank you very much for your patient hearing. And if there are any questions, I think at the end of the session, after Dr. Amin's session, we can take it, Dr. Karan.
Thank you, Dr. Basir ma'am, for the wonderful topic and the wonderful take-home messages that we have. And now moving on to the next part of the session with the second lecture, I would invite Dr. Rudri to introduce Dr. Jayesh Amin, sir.
Thank you so much, ma'am. And thank you so much, respected Dr. Archana Basir, ma'am, for such an insightful lecture. And going forward, we will be having another very, very important session on the topic of low AMH, what is next. As being an ART consultant, we all know that how low AMH significantly affects the fertility outcome. So to address this issue, today we are privileged to have Dr. Jayesh Amin, sir, from Ahmedabad with us. Sir is Clinical Director, Nova Wings Academy, and the President of Association of Reproductive Immunology and Genetics. He has over 25 years of experience in the field, and he has trained multiple gynecologists to become ART specialist. Sir is National Advisor of IFS and a patron member of Gujarat IFS. We cordially welcome you, sir, and over to you, sir, for your session.
Thank you so much, Rudri, for a kind introductions. I'm just sharing my slide. And at the outset, I think so. And thank you so much, Dr. Archana Basir, Dr. Kalyani, all for inviting me. I think so. My slide is visible now. So, am I audible and my slide is visible?
Yes.
Yes. So let's start something which is a very interesting, and day in, day out, we people are having a problem which is low AMH. And let's say the lecture is low AMH. What is next? How we can deal this low AMH? Look at this first picture, which is something like a desert. And we are feeling same situations in our clinical practice when extremely low AMH. It's so difficult to something which grow a greenery on the desert. This is how difficult that we have to give a baby with their own age in the low AMH patients. So we are asking something low AMH, what is next? But once I say low AMH, it is 2016 story. So many people are standing here and they will say something about, I know it, right? And that is what you know. AMH is a glycoprotein which is secreted by 4 to 8 mm of the antral follicle, and which is called as a AMH inside the blood. Now, as we know that, as we decide that which are the patient is good prognosis and low prognosis, if you look at the paradigm of 1990 to 2016, we started with the age and BMI, and today we are falling on the AMH and AFC. And I think so in my practice, I have a vast experience of the polymorphism, that how we can work beyond AMH to segregate and decide which type of the dose should be adjusted. But as we know, this is the table that I'm following in my clinical practice, 2 to 3.5. I know this is what practically we are doing, 2 to 3.5. That means it's a normal AMH. When the AMH is more than 3.5, it is called as a high AMH, or we can say it's a polycystic ovary or hyperresponder. And whenever the AMH is less than 2, the story starts. That which we can consider as a decrease over in reserve or the low AMH. But if you see the study, which is the publication, which is telling us that whenever the AMH is less, the sensitivity and specificity is more than 80% or 90%, where your AMH is falling between 1.2, and whenever the number of the antral follicle count in by sonography will be less than 7 or 10 oocyte will be there, we'll be considering as a low AMH. So now we define what is low AMH, but then what is next? And that is more important. The question which is in our mind when we are treating low AMH, whether this report is required any correction, should we act on this report, a one piece of the paper, and should we act on that piece of paper? Should we ask about the age of the patient? What is the importance of the age of the patient? What will be the reason behind it, that why this AMH is falling down, which is a very frequent question of the younger female, those who are repeatedly asking why doctor my AMH is fall down. And what will be the future advice for the fertility? How can you segregate that, okay, this is for you, it's expected management, for you is IUI, and for you it may be IVF. And when we are talking about this piece of the paper, look at this piece of the paper in and out in your practice, and 0.11 AMH. Would you say this piece of paper and say, okay, you are a low AMH and I'm going to act? I say, no, please don't act on this piece of the paper. Then why? Because there are some variations. And what about the variation? The total variation is still in our practice around 20%. It may be analytical variation. It may be a biological variations. Look at by one, what is analytical variations? And if you see the analytical variation, the 30% of the AMH assays are still not correlated clinically. Because maybe, what is the reason? The lack of international standardized material, maybe in the different part of the country, maybe is a different. And the reagent in the antibody design, which are the most important part, where the AMH is different from the different lab. It's not only lab, but look at that, the temperature, the physical handling, the contamination, the hemolysis, lot of things are going to affect on the output of the AMH is there. But it means what? The message is very clear, that we cannot rely on the piece of the paper, only one report on the low AMH, and we can act according to that low AMH. A lot of myths are there, a lot of facts are there, maybe not myths, but facts are there, that previously when the AMH which was there, we believe that, okay, we can act on this AMH is so sensitive when it was not downregulated by the pregnancy or the leupride or the ossifrates. But then again, in this today's literature, what we can say that this is the 27,125 individual study on the contraceptive users. And look at that output, that contraceptive will reduce the AMH. So the history is so important. You are so busy, doctor. And when you are treating the patient, if there is a contraception down regulations, you should at least ask that what exactly they are down regulated by the contraceptions or not. And if you ask me the biological variability after analytical variability, this is, I'm giving the example of Sharmila Tagore from 20s to 40s, then age-induced long-term variability. It's all about the Sharmila Tagore between the 6 cycles of her own menstrual. This is called short-term variability. And what is ultra short-term variability? That means in one cycle, this is called ultra short-term variability. Age, there is no doubt about it. This is the diagram which says that age increasing, the reduction of the quality as well as the quantity of the antral follicle. And this is a beautiful diagram which I want to say that yes, after 20s of the age, the AMH will reduce. But look at the 1 second diagram where we can say 14 to 16 or 14 to 18 of the age, which is typical. There will be something downfold and then there is an increasing. If you see in the 0 to 10 years, there is an increasing trend of the AMH. Then it is increasing up to 14 years of the age. But typical, there is observation that between the 14 to 18, there will be slight reduction and then followed by increase and that followed by reduce. This is the pattern that usually seen in the humans or in the females, that what I can understand. So during that age might be, it will misguide you regarding the piece of the paper of the AMH. Now, what about the short-term variability? That means her 6 cycles, maybe she is coming in any cycle to go for her treatment. And is it any cycle matters? I say yes, it is matter. When it comes to low AMH 1.2, anything plus or minus 0.3 variability, it matters. It will change your diagnosis. And that is what I say, that is plus or minus 0.3 variations will be in the between the 3 to 6 cycles of the antral follicle variations will be, or AMH variability will be there, which is visible inside the females. And what about the per cycle? That means in the menstrual cycle from follicular phase to late luteal phase, from starting of the commencing of the menstruation to having a menstruations. So this fall phase, is there any ultra short variability is there? And the answer is yes, but it is not analytical variability. It is all about the biological variability. And look at this study which was done for the to find out the biological variability. This anti-mullerian hormone in the systemic review and meta-analysis, we had studied around 259 patients and 257 patients, and we found that the follicular AMH is higher than the luteal phase. So there is no doubt about it. When about you are having a low AMH, you need to ask. It's previously we know that at any phase you are doing AMH, it's fine. I said no. Now it is so important that in which phase AMH which was done, and when you are on the low AMH, it is always better to do in the follicular phase. One more publications which is again saying that follicular phase AMH is slightly higher, and it is so important when you are standing on the low level of the AMH around 1.2, it will change your diagnosis. So this will end up with that follicular phase is definitely having a higher than the luteal phase will be there. Now this variation, it is also visible. This is one more study that you can see that early follicular phase having a higher than the late follicular phase. And let me tell you that because of that, we need to go and correlate clinically. It's not only one parameter will give you the idea of the fertility power. It's all about that you need to go by the fluctuation of the AFC also. But this again one more study which says that not only AMH but AFC also going to variate. And the doctor is really confused where I can believe, whether I can believe on the AMH or AFC, what to use. And to find out, I think so, the discordance between the AMH and AFC. This is one more study which was published when Group B and Group C where AMH and AFC are discordant. That means here the AMH is higher and AFC is lower, AFC is lower and AMH higher. Where to believe? And at the end of the day, we understand that whenever there is the AMH is lower, the discordance is there, the AFC is more standard. You can have a more oocyte retrieval rate when we believe on the AFC. And this is how the retrieval on the verge of the AFC, and volume is also important. So what we believe that AFC is more standard when we are using a low AMH. Now again, this is one more study which was published in the variation in the menstrual cycle, and you can have a 2 or 3 waves in the variation. So this is what we can say, that any time you can stimulate because you have a 2 waves or 3 waves. And from that, I think so, there is a considered as a luteal phase stimulations or random start stimulation, which was started. And you can start at any point of time. And look at this in the fertility preservation patient, the cancer patient, it says that even you start in the follicular phase or even you start on the luteal phase, the number of oocyte retrieval will be the same. Why I want to say that? That means the AFC is always better, and something which is called random start will be really a part of the treatment of the low or decreased ovarian reserve or the low AMH patients. So I believe the second message is always clinically correlating the low AMH with the AFC is a better in decreased ovarian reserve. Now, let me say that never ever treat the infertile patients on a single parameter as a decision maker. Always correlated with the antral follicle count. Now what we are having, when we have a low AMH, the question is like that, should we wait or should we act? the expected management. And let me tell you one thing by this publication, that AMH will never going to reduce the per oocyte convert into the quality of the blastocyst. That means fecundity is not going to reduce. And if fecundity is not reduced, this is one more publication in support in 2017, which was 3,044 patients prospective study, and these couples are allowed. They are between the age of 30 to 44 with different AMH from 0.7 to 8.5 AMH, and they allowed to go for 6 cycle and 12 cycle probability. They observed, and their fecundity is observed. This is 30 to 44, and their fecundity is observed. This is something about the more white people are there, and the Asian people are also somewhat Asian people are there. And what will be the conclusion? Conclusion is, out of 750 people, 487 people are conceived during the next 3-month follow-up. And look at that AMH segregation. Up to 0.7 AMH, the live birth rate, or we can say the clinical pregnancy cumulative probability of the conception is 0.7 AMH is 65%, and 0.7 to 84.4 AMH is also 62%. So it is not decreased. So what it going to give a message that up to 0.7 AMH in the specifically younger group of the patients, I will like to say that don't act immediately. Allow the patient to go for spontaneous conception if there is no risk factor associated. There is no point to refer the patient by looking to report of 0.7 AMH. This is what they show, that the cumulative live birth rate is around 70 to 68%. Any AMH will be there. It's not about to act directly to refer the patient for IVF. It's not about to low AMH to refer the patient for egg donations. They do have a chance of spontaneous conceptions. And this is the message. Only the limitation of this study is the cutoff value. Beyond 0.7 AMH, they don't test it. So I like to say that there is no study which they assess the point less than 0.7 AMH. So I used to say yes. If the AMH is less than 0.7 AMH, that means if the ovarian volume is lesser, age is higher, if the antral follicle count is less than 5, yes, or less than 4, yes, you can go, and you can go by the aggressive management, though the study is not published for this type of low AMH will be there. Again, I am repeating, it will not also reduce the time to get pregnancy interval. So people say that it will take more time. No, AMH there is no concern regarding the time to get pregnancy interval. What about the IUI? If there is a low AMH and IUI, look at the literatures. And this is one more literatures. I want to say that the prognostic factor with low AMH is more important. This is one more study where a 370 patient when the AMH is less than 1, and another 2,649 patients when AMH is more than 1. And look at here that post-wash motile sperm volume is around 55 points. So male factor is very good. If you see the number of the follicle at the time of SCG is 3.5 and 3.4, and the BMI is also low. So this is more important, that here the pregnancy rate by IUI is also comparable in the low AMH and also the high AMH patients. So don't advise to keep on the patient to go by IVF. You can try for the IUI if there is no associated risk factor will be there. Again, should I treat this patient with the letrozole, or can I treat by the gonadotropin? And look at this study, and this study is saying that the letrozole in the low AMH and the high AMH has the equal result. In the advanced maternal age, even the letrozole is equally effective with the gonadotropin. And I want to say in the younger group of the patient, I think the gonadotropin is having a higher success rate in the high AMH patients will be there. Though whenever you are using a gonadotropin, the multiple pregnancy rate is very higher. So it's all about that, how you are treating ethically patient to giving a single baby is always good. My future is single embryo. My future is single baby always. Now this is again one more study. Which are the risk factor? I say obesity, yes. I say low sperm count, yes, when I'm going to be aggressive. The third risk factor that what I found, that if there is a low AMH and if the patient is having a more recurrent pregnancy loss, and look at this study, This study is saying that when patient is having a more recurrent pregnancy, less and low AMH, the aneuploidy blastocyst, the aneuploidy ratio is very high. So now what we understand, should IUI replace the IVF as a first line of the treatment in low AMH? I said no. But where IVF will stand? IVF will stand when there is a duration of infertility is more than 4 years or more than 7 years. IVF will stand if there is a morbid obesity with low AMH. IVF will stand if there is associated low sperm count. IVF will stand if there is a PID, one tube block or something about the hydrosalpinx. And IVF will stand if associated with the RPL endometriosis. Rest of the all other patient up to 0.7 AMH, you can segregate the patient to advise the patient to go for a natural expected management or IUI. There is no need to send the patient. Unnecessary patients will go into the more toward the donor cycle. Now, fecundity is never reduced, but associated factors matter. This is my message. Now, let me tell you something. When you are doing IVF, how you are navigating the IVF. IVF low AMH first counseling is so important because emotional aspects are so disturbed because of the Google reading. Challenges are that you need to explain the patient, and possibility that with their own age, it's always you need to explain the patients. Now, this is how I'm stimulating my patient, specifically when the low AMH patient in Pusodin group 3 and 4. This is my protocol, that how I stimulation. I believe in random start stimulation is my pattern strategy. Why random? You are already having a less number of the antral follicle. Now find out your random stimulation, that find out whenever the variability is higher than the lower baseline. So first time you stimulate and there are 3 oocyte will be there. Then you can see the patient randomly every 10 days. And whenever the antral follicle count is higher, I think so you can start random. AFC matters. So whenever you are having a more AFC, it's better to start. And more, my strategy is cryoaccumulations. So I will explain my patient. This is the retrospective study that you can have a more cryoaccumulated embryo and you can transfer in the successive cycle. More FET cycle with or without PGT will give a more answer, and there is no doubt about it. And that is what I explain my patient, that be ready for the multiple cycle. I think so recent lot of literature which was published in ASHRAE that multiple cycle is better than the single cycle explanation, specifically in the low AMH patients. And we used to do cryoaccumulation and multiple cycle in Pusodin group 3, Pusodin group 4, where there is a low AMH will be there. But when you say cryoaccumulation, look at what I want to say, my own lab data. That your blastocyst, lot of people are still on day 3 on low AMH. I say you are fine if you're not comfortable with the day 5, but the center like me, even my blastocyst ratio, even the M2, this is my 9-month blastocyst ratio of 390, M2 of the less than 5, M2 will be there. Even my blastocyst ratio is 55%, which is as compared to when I have a more M2, even 25. So my M2 in my lab is good, then I can grow the embryo up to day 5. So the stimulation, I say cryoaccumulation, I say day 3 and day 5, depending on the lab comfortability, how you reach to day 5, right? Though there are some chances of RS ratio, you need to explain the patient is part and parcel of the game will be there. What about the add-on? I believe that LH is superior. So you are adding lot of micronutrients and you are not adding LH, there is no point. Specifically when there is advanced maternal age and low AMH, LH is always better than the other. If I want to add, then I will add vitamin D, zinc, and vitamin B12. At the outset, I can say sometime I can prescribe CoQ, but I will be more supportive of the adding LH and specifically HMG. There is no doubt, and I'm so much clear that there is no point to add recombinant LH, is only HMG with FSH. The double, that means mixed therapy is more important. Now, what about the ultra low AMH? Ultra low AMH, and this is a study of 0.16 AMH. Why I am putting it here? Look at that, a live birth rate of 0.16 AMH patients. A phase cycle live birth rate in 5,087 patients is 9.5%. So don't refuse and just say the patient for egg donation. Even the 0.16 AMH do have a 9.5% live birth rate. The people, those who want to get their own egg pregnancy, here you can advise the patient that ultra low AMH also, there is no limit that you can say something about that you will get only egg donation will be there. So this is the study which was published. Another one more study which give immense information. This is the Japanese study which was around more than 14,000 patients in the natural cycle stimulations, and one egg, one sperm ICSI and one embryo transfer. Look at the fecundity ratio of one oocyte is ranging from 4 to 24%. That means a one oocyte can give you a pregnancy around 24%. Chances of healthy baby will be around 24%. This is how I explain, and not cancelling low AMH patients. Even the one oocyte, one follicle will be there because it's not a normal responder. So don't refuse and advise egg donations in very extremely low AMH patients. What to do now when stimulation fails? Now you are doing stimulation, but in low AMH, no retrieve, no M2 retrieve, not more than 3 eggs, no eggs, and repeated fertilization failure. These are the very refractile ovaries, where I know that evidence is always against. The recent publication in the ASHRAE, they are much more now focusing on the personalized medicine. So I believe that there is no good evidence, but we need to focus by person to person, personalized medicines. What happened in this patient when the hormone is not effective? Because these follicles are primordial follicles, are dormant follicle, the sleeping follicle, they need mechanical irritation. They need something, a growth. We can't increase the number. We want to improve the primordial follicle to convert into the antral follicle by activating them. For that, two technologies important, the mechanical irritations and ovarian pricking. So this is how I am saying that. I will always see, there are a lot of study, but all study 0.6, there is no need to do PRP and all these things. We are doing only all rejuvenation if the AMH is less than 0.3, if there is a previous stimulation failure, if there is a previous 2-cycle fertilization failure, then and then. And what I will do, I will first do ovarian pricking. This is my own 15 patient experience, and another 15 patients are coming. That mechanical irritations in the next 10 days, every 10 days, if you wait by ovarian pricking, then you will increase the antral follicle count by the baseline antral follicle count. And this is how I am doing if I am doing a PR pricking, if it is not effective, I don't want to do ovarian PRP. I believe more on the ovarian stem cell, where more growth factor and stem cell will be effective. I believe in more laparoscopic ovarian stem cell. And if it is not effective, I've done very few cases, which is called in vitro activation, removing of the cortex, mechanical irritations outside, adding P10 and some other activator, and then add inside the retroperitoneal aspect under the ovarian fossa, and then you can stimulate the ovary if IVF is required. This is my 15 patients of ovarian breaking. Look at these are all patients 0.3 AMH. I don't do 0.6 AMH and I don't do ovarian PRP. No need. Cryo accumulation is quite effective. Do when stimulation is not effective. Do when you are having less than 3 antral follicle. Do when the volume is less. So I will like to, volume is good, but AFC is very less. I will do first antral follicle, the pricking of the ovary, and I do have a lot of number of the oocyte and look at that output of the embryo. And we are still looking for our own pilot study that will publish sooner. But this is my experience of ovarian pricking. Let me tell you that if ovarian pricking is not effective, then the age is higher, volume is lesser, the antral follicular is lower. We can go by laparoscopically ovarian stem cell therapy by doing just inserting by one prick at the hilum where the blood flow will be there. And if everything is not effective, when there is less than 1% chance of live birth, or patient is not ready to spend the money, if patient is physically not ready, in that condition, the last option is egg donations will be there. I know that the prevention is always better. And I think so the future people will realize and they might go by the preservation specifically in the endometriosis. And we will not do another most important part. Why we found the iatrogenic Iatrogenic low AMH is nothing but unnecessary surgery, unnecessary laparoscopic surgery. So I will request my fraternity and I will request to all the women to do have a one more Facebook campaign. Hashtag don't touch my ovary. This is what I want to say to all the low AMH patients, that iatrogenically we found a lot of low AMH patients. So this is from my side, that how can you treat the low AMH patient. Thank you so much.
Thank you so much, sir, for such a beautifully crafted lecture. I really remember the day when I called sir and asked that, sir, kindly suggest me a good topic. And sir said, no, doctor, there is no good topic. You just give me a topic and I'll make the most informative for our listeners. So that's what we all have witnessed today. Rather, I would say that we are having a great day today because first we had the privilege of listening from Dr. Rachna Basir ma'am. Secondly, we have heard Dr. Jayesh Amin sir speaking on the most significant topic. And going forward, I would request our chairpersons to conclude both of the sessions. I request our chairpersons, Dr. Hitendra Somani sir, Dr. Kokila Desai ma'am.
Excellent talk, Dr. Jayeshbhai, Dr. Archana Madam, and you have really touched the topic in depth and very insightful information about low AMH. So many people are doing unnecessary procedures, and really informative talk, Dr. Jayeshbhai. It is going to help a lot many people in practice. And Archana Madam, you have explained very well about pregnancy after IVF conception. Thank you. Thank you for informative session.
Kokila Desai ma'am, we want some inputs from you to conclude the session. Dr. Sanjay Desai sir, if we could hear from you, sir.
It was an excellent talk by Dr. Jayesh Amin sir. He is really a pioneer in on-egg pregnancy. Low AMH is a choice of topic for Dr. Jayesh Amin sir. He is a mentor for me. I thank you, Dr. Jayesh Amin sir. Again, Dr. Asna Madam has also revealed a very good topic regarding IVF pregnancy. Is it a different or it is equal? It's a good topic from Dr. Asna Madam also. Thank you, Madam.
Thank you, Dr. Desai.
Thank you so much, all the chairpersons. Now, going forward, we have another stalwarts with us for our panel discussion, and who needs no introduction, and a very well-known stalwart in the field, Dr. Himanshu Bavishi sir with us as the moderator of the panel for optimizing IVF pregnancy outcome. Sir has been awarded with the most prestigious IMA award, and sir is an author of the book Practical Guide to IUI Insemination, and the founder president of INSTA, that is Indian Society for the Third Party ART Techniques. To his credit, there are multiple awards and publications. We welcome you, sir, to join as moderator. Then for the expert of the panel discussion, we have Dr. Sejal Nayak with us. Ma'am is a senior consultant and ART specialist. She is treasurer IAGE 2025, and she has been chairperson of endoscopy committee 2025 to 2007. Ma'am has been awarded with multiple prestigious awards and having multiple publications to her credit. We welcome you, ma'am, as the expert for a panel discussion. Going forward, we have six most eminent panelists with us. Dr. Nisarg Dharaiya, and he is a senior IVF and laparoscopy consultant in Sneh Hospital and IVF Center in Ahmedabad, and additional joint secretary of Gujarat chapter of IFS. We welcome you, sir. Then next we have Dr. Jewel Banker as our esteemed panelist. He is consultant at Bankers IVF and Women's Hospital Ahmedabad, and he is a recipient of Young's Achievers Award 2024 by IFS and having more than 10 publications to his credit. Welcome, Dr. Jewel. Then thirdly, we have Dr. Mona Shroff ma'am with us as panelist. She is senior consultant at Nova IVF Surat, and she has been president of Surat OBGY Society 23-24. Welcome, ma'am. Then we have Dr. Parth Joshi sir with us. He is chief infertility and IVF consultant at Ahmedabad, Gujarat, and has been awarded by multiple prestigious awards and has been a great scholar throughout his career. We welcome you, sir. Then we have Dr. Vivek Kapoor sir with us. Sir has been a great scholar and achiever And sir is an MCH in reproductive medicine and surgery. He is medical director of Birla Fertility and IVF Gujarat. We welcome you, sir, as our esteemed panelist. Next, we have Dr. Molina with us, a young dynamic consultant, and she is an IVF specialist and a cosmetic gynecologist as well. And she has written multiple scientific papers. Welcome, Dr. Molina.
Thank you.
I request Dr. Himanshu Bhavishi, sir, to kindly take the session further.
Thank you so much for this opportunity. I thank, please allow me to share my screen. No, still. Is my screen visible?
Yes, sir. Quite
Yes, sir.
visible.
Okay,
Yeah.
thank you so much, Dr. Archana, for giving me this opportunity. Nice to meet Dr. Nagori, Dr. Alpesh, and Dr. Fagun. Thank you, Dr. Kalyani and Rudri. Now I have a galaxy of consultants with me will be speaking and giving their opinion on the topic of optimizing IVF pregnancy outcome. Now we have two different talks preceding this. One was about the pregnancy achieved through IVF, and one was in the situation how to achieve the best pregnancy chance. Now that is why first question to all the panelists is, what is the most important single factor which affects the IVF outcome? Do you have, means if anything comes to your mind as a first important point that, okay, this is the most important thing?
The age of the female partner.
I 100% agree. Now, age of the female partner is the most important factor because even if you are treating any patient and any other medical conditions which may be there, the age is independently affecting the outcome. Now, then it comes the question, which is the important age, the chronological age or the biological age in reference to the fertility?
So the chronological age is the age of the patient, how many years she has lived.
Correct.
And the biological age is her physiological age, or especially of her reproductive system.
Correct.
So if fertility is to be concerned, the biological age is more important than the chronological age.
Correct. But is there, I agree with you, but now how will you explain, in the sense that you have a patient who is, let's say, 33 years of age and has about, let's say, 0.5 AMH. Now, how would you counsel?
I think
How would you counsel? Yes.
chronological age is equally important.
Yes, both are important.
I mean, 0.5 AMH at 28 and at 33. I mean, both are the same biological age. But because of the chronological age, the younger they are, I mean, the better the egg quality, I mean, the mitosis, meiosis, the DNA function repair
Can
is.
I?
Yes, yes, please.
So the chronological age is mainly related to the quality of the egg, and the biological age is mainly related to the quantity of the egg. So we know that both are important, but the quality is mainly determined by the chronological, and the quantity is determined by the biological.
And it can be measured. I mean,
I would
chronological.
slightly differ to this opinion. Even with the lower chronological age, there are certain epidemiological factor can affect that. The patient is a chronic smoker, even at a particular age at 28 or 30, her oocyte quality can be, or her husband's semen parameters can be of a poor quality. So I think both has a role determine the prognosis of the IVF outcome.
May I request those who are not speaking or other members who have joined the faculty link may mute their so that some noise may be avoided. I think we have a very good answer, and the debate is also very justified because both the factors are totally independent factors, and a lady of 30 years produces two eggs. Yes.
भरना है क्या?
Archana ma'am, can you please mute your phone?
Kishore, can you please mute Dr. Archana?
Okay. A lady of 30 years producing two eggs and a lady of producing 40 years, I mean, lady of 40 years producing two eggs is a huge difference. So, as very rightly said, that both the things are important, and that is where it is very important for us to individualize the treatment protocol and counseling of a patient as well. So, now how would you evaluate that ovarian reserve? we had a talk on AMH. We'll discuss that later, but like, how would you explain or evaluate the ovarian reserve in an individual patient? In
There
other
are so
words, how
many
will you try to judge the biological age? Yes, Dr. Nisar?
There are so many ways, but specifically depending on the skill, generally as an IVF expert, we majority focus on antral follicle count. And when these expertise or skills are not available, their AMH is simultaneously equally important. And is FSH also we can measure. But clinical outcome in general, we more significantly get on basis of antral follicle count.
So three A's, I guess: age, AMH, and antral follicle count.
Perfect.
I agree.
A grade answer. But in that case, like what Dr. Nisarg says is also
Sir, we
true, in
can
the
hear
sense
you.
that if you are not happy. Now, I am asking you a very specific question. You must have seen some of the patients where you see that the antral follicle count looks good, but her AMH comes low. And when you stimulate the patient, you try to balance that you see AFC like this, you see AMH like this. And surprisingly, sometimes they respond as per their AMH. Whereas sometimes they respond as per their AFC rather than as per their AMH. So what is your take on it? How do you handle it?
Sir, in my experience, I would totally agree with what Dr. Jayesh sir has already explained. We more rely on AFC rather than AMH because AMH is definitely depends on a lot of factors, the pathology lab variations, right? But if you're consistent, you're skillful enough, you should be more relying on your AFCs. That's what I think.
Anybody else has a different experience that you see good AFC, but the AMH comes slow and you stimulate considering only AFC and then you find the poor response?
So, I mean, the AMH tells us the pre-antral follicles. So, those antral follicles which are not respondent to gonadotropins, while the AFC tells you the antral follicle count, which is actually the number of eggs which are going to be recruited when you stimulate the patient. So, both should be considered individually and not as a substitution for each other. And your stimulation should be based on antral follicle count.
Yeah, but nobody says that your stimulation should be based on age as well. So, the same situation, depending on the age, would you make a change in your dose? Would you make a change in your selection of gonadotropin?
Definitely, age is a very important parameter while selecting monotrophin for particular patient.
Can you throw some light?
Especially, let's take an example. If the patient is of more than 35 years of age and AFC count is a lower, then definitely there is a role of LH comes into the play. And when the same patient, more than 35 years of age with a PCO, then your choice of gonadotropin may vary, right? So age definitely
I,
plays a role
I
while
mean,
selecting the
even
gonadotropin.
with a 40-year-old PCO, I might not give her LH, but a 20-year-old poor ovarian reserve patient, I might add HMG or LH to that patient. So I think the AMH levels are the primary guiders, and age is, of course, a guider, but I think secondary to the number of eggs she has.
Okay.
Also,
Any
sir, the
different?
number of patients who have the poor responder patients, the ovaries are little resistant, the chances of polymorphism may be there. So, taking into consideration her whole metabolic profile along with her age, we may decide depending to whether to add LH or not. But adding LH may be pertinent in patients with a low AMH and a low AFC,
All right.
irrespective of
Any
age.
other difference in managing their IVF
I
cycle?
I choose my type of injections based on the age and the dose depending on the BMI. So these are the only two things that I take into consideration. Plus, if a previous cycle has been done and if there is some unexpected poor response, then obviously, but in my practice, I've seen very rarely polymorphisms. So I think we go with the 99% uh, expected response and
So you said you give importance to age.
age
And
of BMI for the type of and the dose.
yeah, so how does it means? Can you clarify?
So if it is an elderly patient, so Posidone 3 and 4, then I do add an LH. Otherwise, it is primarily the dose is dependent on the BMI only.
All right. So we have little difference of opinion amongst the panelists. People think that more advanced age patients, it is safer or better idea to add LH. And of course, dose determination is on multiple factors, age, AFC, AMH, and other things. Now, it's a case of poor ovarian reserve and you are doing her IVF cycle. Any difference in your approach or any difference or any preference in managing that particular cycle?
So let's start with the pre-medication. It's already a poor ovarian reserve. Let's first say for the pre-treatment. There are a lot of things in the basket, mainly CoQ and DHESR or testosterone gel comes into the picture. I think theoretically everything has a role and it should be given for a bit of a 2 months or 3 months. That is a pre-treatment. In the actual stimulation, a pre-stimulation cycle, we would prefer to give a estrogen primed cycle for more synchronization and recruitment of more AFCs. Then choosing the protocol. That is also a very important part. Whether to add LH or not, that is already been discussed. And yes, if it is available or is available, I would prefer to go with hormonal monitoring, maybe 2 or 3 times a cycle, whether to increase the dose, especially of LH or not. And yes, choosing the trigger based on the hormonal monitoring and the number of AFCs, number of stimulant follicles available at the time of trigger. So these are the different strategies you can apply when stimulating these cases.
If I say
I
in
think
short, you said you will give pre-treatment, then you will start stimulation, and you will do more of monitoring. You would prefer to give LH. That is what you said, probably. No? Yes.
So basically, I have experience of two protocols mainly. Right now, we are using two protocols. One is optimal dose stimulation, and another thing is high dose conventional. So I'll personally prefer to give you the optimal dose along with maybe we can use CC and letrozole along with that to reduce the gonadotropin doses and increase the efficacy.
All right. So there are multiple things which he has said. Now, first, my question to other panelists: would you like to wait for 3 months for pre-treatment, or you would like to start the treatment?
1 month pre-treatment, especially just to add cycle synchronization by luteal phase estradiol. Uh, I wouldn't wait for 3 months, 3 more
Okay.
months.
Anybody has a different opinion?
Sir, we can also counsel the patient regarding regenerative methods that include ovarian rejuvenation and then probably wait for a month and then go for oocyte pooling.
All right. Now, this is again the opinion of others on ovarian rejuvenation.
This
Would
would
you
not be
like?
for everybody, but in certain patients, we can definitely counsel
No, but
because
why
now
not
there are
everybody
studies.
and why certain patient? No, that is a question. You know, who will,
Uh,
means what is your selection criteria?
So, sir, normally patients with poor ovarian reserve would be the ones who are, irrespective of the age, having a less reserve, say a AMH of less than 0.5, zero point 0.4, in a patient whom we would otherwise, who would go for a donor egg. So if a patient with poor ovarian reserve with a previous failed cycle somewhere, somebody has not got a good embryo quality, not enough number of oocytes, is desperate now to reduce the time to pregnancy, then we may give this option to them. Many of them do not even agree for it. In those cases, we don't necessarily stress on this only option, but it would be a mix of or an addition rather of ovarian rejuvenation along with adjuvants for a month and then start the stimulation.
All right. So we will not waste time in discussing the controversy, but I would like opinion of anybody who is doing and has good experience or bad experience.
Not doing.
So,
Anybody else doing ovarian PRP or yes?
ovarian PRP and stem cell exosome therapy. Not a very dramatic improvement or magical improvement. So a pre-counseling we do, whether in some patients it does work a little bit. Average, we are getting maybe one or two extra eggs.
So I agree with you, and my personal experience is the same. So we counsel, we tell the patient in simple language, 19 bis ka difference or marginal improvement. But for a patient who is having 2 or 3 eggs, marginal improvement of getting 1 or 2 more in some patients also can make a big difference. So we'll end the controversy here about PRP.
Can I
Next.
can I
Yeah.
add on that part?
Yes.
So like PRP, it is a like where it is going to act. It's a growth factor. Growth factor act on the stem cell, so stem cell can divide, and it will give us a better response, like in the endometrium, like in the testicular tissue. So the oocyte is not from the stem cell. So whatever we are thinking कि PRP is gonna helpful for that, it is might be that our puncturing is helpful, might be we are reducing the pressure that is making changes, or it is the variation of the like a 1 or 2 egg of the variation. That is also 100% variation. They are getting a 1 egg or the 2 egg. So PRP and the stem cell in the ovarian side, it is shown it's a non-useful, and the like any scientific logic is also not that behind. So
Sir, I
still
think
we are
that
doing in the
Now,
same
now,
patient.
sorry to say, now we will not discuss it more because we have so many other things to discuss.
Sir,
People
I just want to
express their
add one
opinion.
point that every center should gather their own data, analyze, publish the data, and find out if it is significant or not.
Yes,
In
yes.
that
Next.
context, we
Okay.
have
I
done
agree
that.
with you, but
So,
as I said that let's move on. Let's move on. People have expressed their own views. Now we discuss anything apart from that. Anything during stimulation, as Dr. Path said, he will do hormonal monitoring. Is it somewhere helpful because just because it's a poor ovarian reserve, or it's okay, it's just like simple monitoring of any other cycle?
In a poor ovarian reserve, generally synchrony of the follicle in a pending follicles are very important. So in that case, previous cycle estrogen supplements, and then if we start the stimulation, that is somewhat better because already we are running with a lack of lack number of eggs. And one more thing, many circumstances we have seen long protocol has given somewhat better outcomes after down regulation in such cases. So that can
So this
be
is a
considered.
very important point brought out here, that if you got a optimum response as per expected, then you may follow the same protocol for the patient, maybe. But if it has not given, then it is definitely worth trying the another protocol. Just don't say that it downregulates or it doesn't give good response or so. Maybe you may give little higher dose if you feel that. But that is definitely a very important point, and I agree with it.
sir, one
Now
more
during
thing, if we can do
OM
it,
pickup, any
go
difference
for
between,
duostim.
sorry?
Luteal phase stimulation in poor ovarian reserve patients also gives excellent outcomes in
Yes.
terms of
So
mature
so
oocyte.
you can that is another way of doing cryoaccumulation, that either you do dual stimulation or repeated cycles, freeze the embryos. But my question is that during OM pickup, if you have only 1 or 2 follicles, any difference?
I mean, that is the indication to measure estradiol levels, because sometimes there can be empty follicles also in patients with very poor ovarian reserve.
We prefer to do
And
flushing of the
dual
follicles
trigger.
in this case, wait till we confirm that we got the egg and then move on, because this is a very less number. I know very few people do it. Anybody else does it?
So if the follicle oocyte ratio is correct, then we don't do it. Otherwise, we re-aspirate.
Yeah, but you don't get that answer till the time you are done.
Yes, so
So
in the first instance, when we do the egg retrieval, and if we get the expected number of eggs, then we wait till if there are very less follicles, we wait before going to the next follicle.
yeah,
There are only 2 follicles.
So we aspirate one, we wait till the lab tells us that they have found the egg, and then we decide whether to re-aspirate or.
so many times in one follicle, the egg is lying in the tube. So, or in the needle also sometimes.
So Himanshu sir,
Anyways, we prefer. So now the next question. Any
Himanshu sir, sorry,
difference? Yes, sorry,
Himanshu sir,
please.
no doubt you are the moderator, but can you please share your experience which you just highlighted
About?
about the special precautions which you suggested in low AFC count?
Yes, give adequate dose. Try to monitor only by your routine
No, no,
sonography.
during pickup, sir. You
During pickup, we do flushing of follicles always. And we flush the follicle, wait till we get the egg, then only move on to the next. So that is the standard protocol, standard thing which we do, at least below 4 eggs. Because even you get one more, it is 33% or 25% for the patient. And the people who have only one or two, it becomes 50 or 100% as well. Now the next question is that you got the follicles, you aspirated, and you got one M2, two M1, and two GVs, or let's say one M2, one M1, and two GVs. What would you do? Any other strategy to help this patient?
So we can give the option of in vitro maturation if
Mhm.
it is available in the lab, and that will also help to optimize the immature oocytes and the GV oocytes, and then they will be fertilized.
Anybody else?
In the stimulation, I would give dual trigger in poor ovarian reserve.
That's perfect. Now, probably everybody gives dual trigger to every patient. Is there any difference of opinion here?
Only in poor ovarian reserve patients.
Only in poor, especially to avoid in hyper responders, not in
No,
every
no,
case.
hyper responder is a different category. Of course.
Otherwise,
It's
in
not that.
every poor ovarian reserve, you go for hormonal monitoring and you can give to every patient dual trigger. What's the harm?
It's much more safer. You know, the most important problem we faced in IVF was poor trigger. You know, everything good and surprisingly no eggs or a poor number and all those stuff was mainly, and we were not happy with the HCG. We used every types of HCG, HP, recombinant and combination dose, 5,000, 10,000, etc. And we found that sometimes the patient, rather than taking HCG, took HMG or something like that, and all those stuff. So now, safety-wise, most of the people are giving dual trigger because there is no harm, at least, and there is a whatever is the advantage. So hyper responder we are not discussing, of course. So that is different category. How many of you culture GVs to maturity and use them? Yes, Molina says yes.
I don't think GVs can be cultured in this way after full cycle of stimulation. I've been to Vietnam where they do IVMs for almost all patients, and the process of doing IVM is totally different. The eggs are usually unstimulated. They take it out at a very precursor stage, and the process to culture embryos by eggs by IVM is, I think, not yet available in most countries, especially
I
in.
have done many cases where GVs have given live births. So I think please try it in your own labs. It's not difficult. And it can be a very big difference in this group of patients where the number is very less, or you sometimes end up with more GVs or all GVs or any situations. So
Sir,
you
you need the
try
right resources, and especially if you see the majority of the IVF labs and senior practitioners, even in Japan, this is a very, very normal procedure for them. You need the correct media, you need the optimization in the lab and the protocols. It is a very, I would say, a very niche thing, but it is
It's very
definitely, it can be
difficult and
done.
long thing to discuss. So let's not discuss IVM, but message what we want to give is that when you have very less number of eggs, don't throw away GVs.
Molina,
Can be game
I
changers.
want to ask something because what exactly you can do in a stimulated? We have a very worst experience that when there is a stimulated, there is no point of GV will convert blastocin and blastocyst convert in live birth. Well,
So
which type
many.
of media? Because we believe that non-stimulated is okay, but I don't
Definitely,
We
believe
have
sir.
so many live births.
means that is something. Is it
Sir,
really
but there
GV?
is an
And
option that
which
we can
media you
give.
are using so we can use?
Sir,
The same.
it is a media that we have got with the collaboration that we have from Dr. Kawamura in Japan.
Huh.
And this media, because it is an expensive affair, we are not doing for everybody, but we are seeing good results, especially in patients, especially in young patients with M1 oocytes. M1 more than GV, I would say, but definitely in M1 oocytes. And even GV, we do IVM, but it gives a really good outcome. Sir, we can
M1 cannot convert to M2. Only GVs can convert to M2.
After denuding,
Sir,
like
we are doing after denuding and then ICSI is done. But it can also be done before denudation and then you can go for IVF. That will
I
depend
think
on
this
the
is too
protocol of the lab.
technical for the audience, and maybe we can move on. Now let's forget the egg. We did a lot of discussion on eggs. Does semen parameter also impact
Yeah,
the
no
IVF
doubt, sir.
outcome?
Definitely, semen
Definitely.
parameter does lot of impact, but after ICSI and IMSI, it is great help for any IVF practitioner and related to outcome. But other way around, in traditional conventional IVF, it makes a lot of impact, and fertilization rates goes very down. Even though after choosing in ICSI, the conversion ratio in severe oligoasthenotereto patient or some such kind of sperm parameters, uh, the conversion ratio into blastocyst definitely less, and abortion ratio even after using ICSI-IMSI, abortion ratios are high. So preferably PGS we have to consider if we are getting good blastocysts.
Yes, Joel.
Semen parameters do play a role, but after ICSI, the role is quite
So
limited.
first
But
question comes in that people keep on saying that let's put it, it's a good semen parameter. How many of us are doing regular fertilization or conventional IVF?
we do half in cases of PCO patients.
Oh, that's okay. But in routine IVF, routine patients.
Not in routine.
So practically we have given up because we have seen so many unexplained fertilization failures, even in good semen parameters. So that scares us, and we don't have any explanation, and we don't have much rescue as well. So to be on the safer side, we have embryologists doing the job, and it gives good result, etc., etc. So practically, that concept, which is always promoted by many, that you should do conventional IVF, this, that, and all, but is not practiced because of the personal experiences. Now, what Dr. Nisarg says is also very true, because first of all, we don't know why the semen parameters are poor. And so many people, so many men are physically normal, hormone-wise normal, sexual function-wise normal, means otherwise they are absolutely normal, but their parameters are poor. And that is where there are unexplained elements. And that is where the next question is that, do you find in your own practice, don't go by literature. Literature says different or whatever it says. I am asking you about your own personal experience. Any difference in pregnancy achieved through ejaculated sperm versus any form of testicular epididymal aspiration or whatever, but non-ejaculated sperm?
I think for our center, the normal ejaculated and PESA samples do give equal results. But if, I mean, the sample is a for testicular biopsy with absolute zero motility and it is a compromised sample, then we might have lower blastulation rate.
Anybody else?
So, can I tell you my experience? The testicular sperm of the non-obstructive azoospermia, we are having a less fertilization rate, less blastulation rate, as well as the somewhat less pregnancy rate compared to the general population, compared to the ejaculated sperm.
Anybody else?
So basically, in a one specific category, we get a very good results in our own setup is when there is a high DFI.
Sorry,
Right?
high?
High DNA fragmentation index cases in
Okay.
which you prefer testicle sperm because theoretically it bypasses, it gives a more good quality sperm when you directly took it out from the testis.
Okay, great. Now that is again please share your experience, other experts. Would you, if you see high DFI, would you go for TESA?
So if it is, there are two categories in which there is a high DFI. One is where the sperms are adequate, ejaculated sperms are adequate for any sperm separation techniques like microfluidics or MAX or Pixie. Then, but they in certain cases they are not in the criteria where we can even do a separation. So the ejaculated sample is too low to even separate through any of the techniques. Then TISA we recommend.
Okay. Anybody has a difference of opinion here?
Sir, in what
And
we
one
are
more question I have before you say, Molina. And if it is a case of TISA, let's put it this way, would you like always a freshman or you would freeze?
Sir, I'll answer the prior question first. So whenever there is a high DNA fragmentation index, sir, and a mature sperm can also have a high DFI, and an immature sperm can also have a high DFI. So whenever a patient with high DFI whenever high DFI is detected in a male, we must find out whether there is a maturation arrest or not. So what we do is, so these patients need not be necessarily azoospermic. They might have a normal count or motility. So there is another test which we normally recommend that is called DNA stainability, high DNA stainability, which is called HDS. Now, this test will tell you, it will stain. So when it is, the sample is the sperm sample only. It could be the same sample which runs the DFI also. They stain it with the particular dye, and 23 to 25% again is the same cutoff of the same sample. If the stainability comes out to be high, they claim that, so the test people, they claim that the high DNA stainability comes in more immature forms of sperms. If the patient has high HDS and high DFI, in such cases, doing a TESA is not going to help. Whereas if there is a high DFI and if the HDS is normal, only then doing a TESA is going to help. So this is just one thing that I wanted to add.
And one more question. Would you suggest donor sperm based on high DFI?
No.
Any other evaluation would you like to do? Would you like to do a karyotype of a person?
Yeah.
Not just for the
Severe
not
case.
just for high DFI. If the patient has severe oligoacidoteratospermia, then a karyotype should we do it routinely, but not in cases of high DFI.
Yes, anybody else wants to add? Otherwise, we move on to the next topic. Now, what is the importance of IVF lab in the overall success of an IVF?
IVF lab
I
is actually very much important for a successful right birth. If we give in an actual practical aspect, everything matters. The skillful embryologist, their training, their confidence level, your quality standards of your lab, the monitoring level, the documentation, even the overall environment of the embryology lab per se, your incubators, their quality standard and checks, everything that matters. So yes, definitely IVF lab has a major role to play.
I think the first question we had was the most important parameter for a couple in IVF is the age of the wife, and similarly for I think successful live birth in IVF is the IVF lab.
Yes. So, lab of the clinic.
It's the
The
soul.
lab of
Yeah, but one thing which he highlighted was the environment or the air. Now, you know that most of the equipments which we are using in IVF lab are the same the whole world is using. So what's the difference between the whole world and India is the air or the pollution or the quality of air which we have. And that is where the quality of air which we can produce in our lab by whatever we use, like preferably the air handling units, filtrations, VOC filters, etc., humidity controller, and there should not be any shortcut to that by so many people saying that this is a space saving thing or this is a cost saving thing, which
Mm.
cannot actually generate the quality of air which we really want. So in short, the man and I mean the machine and the man behind the machine, both are important. And the skill of the embryologist, monitoring, etc., etc., what you pointed out is very, very true. And I think this point cannot be more emphasized than any other point, that if you really want to produce not only good pregnancy rate, less miscarriage rate, and good quality of live birth, then your lab has to be the optimum. Now, again, the big controversy: how much importance do you give to PGT in means what is the role? Let's put it this way: how do you see
Definitely,
PGT in an IVF program?
definitely PGT has very significant role, but uh, unrational use has not any significance. But the selective cases or indicated cases where age-related factor or severe male factor, and that scenario or previous IVF failure in that we have seen tremendous changes, or rather it is helpful in some instances, like previous IVF failure with all embryo comes abnormal in PGT will helps us a lot in justifying the reason and taking further decisions, like this is the reason of previous IVF failure. So in that sense, this technology is really helpful in our result outcome.
So I think PGTA has a role in improving live birth rate per transfer, not per patient. I mean, if you have 5 embryos and one is euploid, eventually she would have transferred that embryo and would have resulted in a live birth. But she would have had multiple miscarriages along the way to reach that embryo. So PGTA does increase the live birth rate per embryo transfer, but given the ART Act, and there are very limited indications where we can offer PGTA to the patients, I don't think, I mean, male factor can be qualified as one of the reasons. It is a very gray area, I can agree for sure. But I think advanced maternal age and
Yeah, but
carrier
what Joel said and what Dr. Nisarg said, rational is one thing, expectation is another thing, and the benefit is the third thing. Now you see any patient walking in from abroad coming to your clinic, most of the patient, they either are aware or they demand PGT. And the reason is very simple, that it has become very popular globally. And again, the reason for that becoming very popular globally is what Joel said, time to pregnancy. If you had 3 embryos and when the patient uses all 3, she is going to get the same result as she would like to get. But like you did PGT and it was 2 were abnormal, then the only one which was to give the pregnancy or which was not to give pregnancy, but whatever it is, was actually good to use, can be used and patient can move on with the next cycle. So this is a big, big difference. And that's where the rational part, what Dr. Nisarg said, has to be individualized. Means depending on the circumstances of the patient, history, cost implications, legal implications, etc. But it is a game changer. Apart from, of course, the PGT-M and PGT-SR, which can definitely help the patients who have the indication for that and can significantly make a difference. So there is no controversy, there is no debate there. So if it is an indicated situation and it can help, it has no debate. But when it comes to PGT-A, as rightly said, the time to pregnancy is one factor. The another factor is the singleton pregnancy. Now we have about 5 to 10% of the patients coming for second child who delivered first baby with IVF with us, and they want the second baby. When the first transfer was there, they were okay to transfer 2 blastocysts also because they were okay to have twins. Now they are not okay to have twins also because they have already have one child. So this also is a situation. So means role of PGTA we need to individualize rather than having our own bias about the rationale. And organizers, you can please tell me 10 minutes before we have to end, so we can quickly wrap up. Any secret recipe for poor endometrium?
For us, hysteroscopy is one thing which helps.
If it's a secret, then no one tells, na, sir.
Sorry? पता नहीं, everybody has a different thing.
Wants to
There
keep
are
the
people
secret to
who
himself.
सिर्फ आपको बता रहा हूँ, इस किसी और को मत बताना कह के भी कहते हैं. So, but science develops with this only. So, any of your signature formulas?
So practically, there is a cocktail therapy. The four most important thing is hysteroscopy, definitely. Along with that, use of estrogen, then use of intrauterine PRPs, subendometrial or whether intrauterine. Along with that, a lot of things that you can use is ecosprin, sildenafil, uh, L-arginine, all that matters. And definitely, if the indications falls in, even in thin endometrium, you go for endometriosis panel, you treat the underlying infection if you find out. And yes, if the indication allows, if there is a recurrent implantation failure along with thin endometrium, you can definitely use ERA or endotrium what the genomics offer. So this is a cocktail therapy, but foremost important thing is hysteroscopy first.
So I'll
There is no
decide.
no dispute. Second thing, what he rightly said is the infection screening. Now we have DICE test or other tests as well. So just apart from ruling out the tuberculosis, we can try to find out other infections as well and try to treat. That's two. High dose of estrogen, etc. Various routes of administration of estrogen, etc. Everybody has tried and is also justified. Again, the controversy of how many of you do sub-endometrium PRP injection at hysteroscopy for poor endometrium?
I do.
Mona
I
says
also
yes.
do.
Okay, Vivek says yes. Anybody else?
Yes, Dr. Bhavishi, Dr. Archana Vaser, we also do.
Perfect. So, see, in medicine, it is said, as long as you are not doing harm, you can offer something to the patient which may help. And fortunately, PRP, we have not observed any harm either intraovarian or subendometrial. So that is one of the major advantages what we have. It's not very expensive, it's quite simple, and that's where, and particularly when you are doing hysteroscopy, it doesn't add up to the time as well. It takes just 1 minute to inject at 4 different sites. So that is one thing. But how many of you believe in ERA?
Yeah, still doing
I
ERA.
don't know.
I mean, very less compared to what we used to do previously, but unexplained multiple failed transfers or PGT transfers. And I think it is very difficult to explain that once, I mean, such patients have an era of P plus 6.5 and then they conceive. I mean, I can't think of any other reason. We would have never transferred an embryo at 6.5 days of progesterone. So there are a few indications where we still do ERA. But I think another alternative which we nowadays do is a natural cycle transfer.
Yeah, that is again one more important thing. Before we discuss natural cycle transfer, like you said, it is difficult to explain that why it failed, but it is difficult, even more difficult to explain when you do ERA and adjust the
Comes
transfer
out to be
time and
normal.
still it fails.
Uh,
So we practically have given up doing ERA, and I don't believe, of course, Cochrane also says there is no evidence, but personal experience also matters. We tried in quite a few patients, but we found that it is expensive, it is invasive, it wastes time as well, and it doesn't give us that much of benefit. So that's how we decided not to. But sometimes patients also insist that I want to do it because XYZ said. Now the last debate on add-ons. The list of add-ons is very, 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 very long, and but that helps us becoming, a super specialist doctor by having our own signature protocols by add-ons, and that's where everybody has their own signature add-ons. So, which is the most preferred add-on? I will start with maybe I see Jwal. So let's say, Jwal, what is your most preferred add-on?
I mean, luteal phase cycle programming with estradiol, that is the only add-on which we use. Otherwise, only folic acid for almost all patients.
Dr. Mona?
Yeah, I think we go simple most of the time. Keep it simple. Only
All
in
right.
selected cases we test for immunology and do certain treatments when everything else has not worked.
No, testing is fine, but you whether you have the report or whether you don't have, whether you have the reason or whether you don't have, you see a prescription where you see two, three routes of administration of progesterone, one estrogen, then of course aspirin, then of course you see low molecular weight heparin, even in first embryo transfer, in most of the clinics I see. Then you see, of course, the whatever others like multivitamin, antioxidants. Then you see the FemBio kind of thing like flora regulation and those kind of things. And means the prescription is more than a page. And that is where we know what is the add-on. So I would like to know what is your preferred add-on which can give magic. So we all learn from you guys and
Probably
are doing.
B12, D3.
Sorry,
B12 and D3.
B12, D3. Perfect. Vivek?
So for me, it's I don't use any add-ons. Means D3 if it's less, B12 is if it's less. Aspirin I use for the each and every frozen embryo transfer whenever I'm going for the HRT. Natural cycle don't use the aspirin as well.
All right.
And
Now,
the add-ons is
aspirin,
a
Dr.
repetition
Archana
mainly.
said 75 milligram. Anybody has a different opinion?
I am using 75. Mm,
All right. Nisarg, are you there?
The add-ons are, it should be directly proportionate to your experience, and it should be justify related to specific report or cause. So it is very true that if vitamin D or B12 is less, it is not
I
considered
don't
add-on.
consider it as an add-on
Add-ons.
only.
Yeah, it's
They
not
are all
considered as a
basic ones.
add-on. So
You actually,
add-on
and
is a thing
Indian
where,
women have it less or never have more. So even if you
yeah,
give it blindly, you are not erring. So
yeah.
that is
So
fine. That is okay.
yeah,
Multivitamins, as long as they are not doing any harm, they are not too expensive as well, and they are
same
going
like
good.
PRP.
But what I'm talking about is the LMWH to every patient or
No,
prednisolone
no.
to every patient or all those kind of things.
No. We don't recommend, sir.
Even aspirin is a double-edged sword because implantation is a pro-inflammatory condition. So you cannot simply give aspirin that it may not harm. It does harm.
All right. Now, one more thing, hydrosalpinx. Would you like to leave it alone, clip it, or remove it?
Remove it.
We prefer to remove it.
But
And
which
if there is fluid
hydrosalpinx?
draining, if it is,
Ideally, it should
if
be
there is fluid
removed,
inside
but you just need to
the embryum,
consider one other factor is patient's age, right? It would be difficult if you remove it in certain, then you need proper counseling and concern. Otherwise, definitely salpingectomy is a better option rather than clipping.
Sir,
because
there are lots of studies also that show, and even in personal experience, if it is a communicating proper big proximal hydrosalpinx, we normally prefer to clip and not go for a salpingectomy. However, if it is a small locule of a distal hydrosalpinx, then it has developed in the first place because there is an occlusion, and the distal hydrosalpinx you may leave. But that is what the even the literature says. But the proximal hydrosalpinx, definitely we need to.
So the major problem is that the easily visible, sonographically diagnosable
Net.
hydrosalpinx is a different hydrosalpinx. Most of the times, patient come up with a hydrosalpinx which is diagnosed on HSG. A tube seen little more dilated and diagnosed one tube hydrosalpinx or that. So that is where the major controversy or debate comes in, that would you like to remove the tube or not?
But
You
a
know,
good
or
so
not.
3D
I mean, not in such
disabling
can
that
cases.
definitely
tube.
demarcate the whole hydrosalpinx. A good 3D ultrasound, we can actually find out the septa, the communication, how big it is, where it is in the tube. So that can, a good 3D ultrasound can sort this dilemma, sir.
Sir,
Even,
if USG suggestive of no hydrosalpinx, then no treatment.
even a simple 2D ultrasound is good enough.
Yeah, it's good enough.
All right. Anybody wants to add anything as a advice or trick for a better outcome of IVF treatment or cycle? One by one, I would take. Anybody can start. Dr. Parth, you can start. Yes, Molina, you can start.
So, sir, for
Yeah.
I
Please
was
go ahead, Dr. Malina.
sorry. Yes, sir.
Please go ahead.
Yes, sir. So for optimizing the IVF outcome in any patient, I think, sir, individualized treatment, as everybody is already practicing, good counseling, uh, good optimized individualized protocols, good lab environment, and if it doesn't work, then good support to the patient in retaining the patient, and then troubleshooting and then taking the next step. So that is also very important.
So,
Another routine part, what we usually miss in our busy day-to-day practice, that everything should be documented and you need to evaluate on a weekly and monthly basis. Even your lab parameters, your clinical parameters take shift for a month or so. So you need to you have to correct it every time. And second thing is time to time adaptation to a newer strategies because it's never stagnant. So multimodality approach, and you always have to keep check on your lab and clinical parameters. That's what I think to improvise overall IVF outcome of your center.
yes, Dr.
I
Mona.
think, yes, ma'am.
Yes, I agree with everything else. One additional, whenever we are doing an antagonist protocol, I always wait for a synchronized cycle to start because I feel that is the key. Like in a hurry, when we start in an asynchrony of the follicles, it doesn't give a good synchronized growth.
All right.
I think my focus is mainly on prioritizing single embryo transfers. IVF pregnancies can be different from normal pregnancies if there are multiple pregnancies. So try to transfer as fewer embryos as possible.
All right. Anybody else?
Hmm.
Dr. Nisarg? Yes,
Yeah, just to conclude that whenever a patient comes, so we have to give that priority to understand their need, and rather than coming in a quick decision or random start protocols or something like that, whatever best in terms of the planning, we should make them counsel that we are going to start your cycle after antioxidants or whatever pre-medications require. And then rather than jumping directly onto the starting the treatment as the patient step in. And one more thing related to post consume medications. So many empirical and so many other medications are going to so many patients in up to 7 months, 8 months. So we should again be very judicial in using those medicine, because it indirectly gives a lot of financial burden on a patient.
Okay, next,
Mm.
Dr. Vivek.
So for that, as I will tell as a clinician, so stick to the scientific basics of the stimulation with natural cycle frozen embryo transfer. So scientific stimulation basis is a like mainly the individualization of the ovarian stimulation, and for the embryo transfer is a mainly the natural cycle FET. So that is going to advantageous for our patient as well as for us. And judicial use of the any add-ons, whatever the fancy thing, whatever we are doing, it is not going to increasing the success rate. It is just adding the one burden to the patients.
No, but that this brings up to a controversy. Would you do fresh transfer or would you not do fresh?
Fresh transfer and the frozen transfer, it's like a last 10 years, it's a debate is going on. So whatever the basic strict criteria, like if the progesterone is high on the day of trigger, if
No,
it's
no,
a
we are
risk
not
of
talking
OHSS.
about unsuitable cases. They cannot be. I agree that hyperstimulation
Yes,
risk
yes,
or poor endometriosis,
yes, yes.
etc.
So
We are talking about the routine patients, routine response, good number of
So
embryo.
my routine fresh transfer rate is around 20%. So whatever that thing, it's like if I go with the strict criteria like what we have discussing, then it should be around 40%. Only 60% are generally non-suitable. 40% are suitable, but still I'm doing in the 20%. So it is not like a fresh is not giving the success rate. Fresh is also giving the good success rate if you are choosing
So we learned
the good
IVF
patient.
doing fresh transfers only.
Yes, yes,
So,
exactly, exactly.
so for 30 years, we are doing fresh transfers
Yes,
from day one. So anyway, so if I summarize what everybody has said, that one is individualization, and that is very, very important because every patient is not the same. So if you individualize everything in terms of investigation, pre-treatment, stimulation dose, monitoring, triggering, pickup, and transferring strategies, fresh, frozen, or support, etc., etc. So that is very important. But at the same time, the another point which was brought out by Dr. Nisarg is that the choice of patient or the situation of the patient is also extremely important. We must understand that we are not gods, we are consultants, and our duty is to explain to them what is good for them, what is not good for them, or what is a reasonable chance of success if they do X treatment or Y treatment, and what are the advantages and disadvantages, etc. So many patients, even at the age of 45, 5% pregnancy chance, are willing to try with their own eggs. We cannot refuse, should not refuse. And the patient, so many patients, come with a report, poor quality eggs, advise egg donation. Now, one cycle poor quality eggs does never mean that the patient will always have poor quality eggs. There may be many things which might have gone wrong in that particular cycle, and patient can have. So I have n number of patients who have delivered where the opinion was given like this. So I would like to say that try to understand the feelings of the patient. Don't take the shortcuts. Be honest to the patient and try methodical. So, of course, you have to use your own brain because if you see IPL matches, you see so many shots being placed which were never played when it was a test cricket or one day cricket. And they get 6 runs and 4 runs as well. So, what is important is that you have to be innovative, you have to think differently, and you have to use your own skills, experience, logics, brain, thinking, everything, and individualize. I think we have done a very fruitful discussion here. And over to you, to the organizers. Thank you, all the panelists, for a great job. Thank you, organizers, for giving this opportunity. It was a wonderful time.
Thank you. Thank you, Dr. Bavishi. It was an excellent panel, and all panelists did a wonderful, wonderful job. I just had one thing. You know, I know like IVF outcomes are not predictable at all. And sometimes if the same patient is coming repetitively to you with the failures and you have tried everything, I think these kind of webinars really help you because you come to know that yeah, others are also facing the similar problems. So you can really update yourself and you get some insight into it and you go with a fresher mind to the patient. So I think that this kind of discussions really help you in your practice. So thank you very much for really a good discussion. Dr. Rudri and Dr. Kalyani.
Yes. Thank you so much, ma'am. Absolutely very well said. And I'm extremely thankful for Himanshu Bhavishi, sir, for conducting such a meticulously crafted panel discussion. I'm sure our listeners must have benefited a lot from this panel discussion and it will help in improving their day-to-day practice. I'm also thankful to our chief guest, Dr. Fagun Shah, sir, and our guest of honor, Dr. Chaitanya Nagori, sir, and Dr. Alpesh Gandhi, sir, who joined us and accepted our request. I am also thankful to Dr. Archana Basir ma'am because this webinar is a brainchild of Dr. Archana Basir ma'am herself. And Dr. Kalyani ma'am, I'm also thankful to you for giving me the opportunity and helping me in crafting this whole program. And I'm also thankful for our chairpersons, Dr. Sunil Shah sir, Dr. Hitendra Somani sir, Dr. Sanjay Desai sir, Dr. Kokila Desai ma'am, and our eminent speaker, Dr. Jay Shamin sir. For the panel discussion, I am thankful for our panelists, Dr. Nisar Dhareya, Dr. Jewel Banker, Dr. Mona Shroff ma'am, Dr. Molina, Dr. Vivek Kakkar sir, and Dr. Parth Joshi sir, and most of all, Dr. Himanshu Bhavishi sir, for conducting the panel in a very much informative manner. And I would like to request Dr. Sejal Naik ma'am to expert for the expert comment for the panel discussion. Dr. Sejal Naik ma'am, I request for your expert comment. Okay.
Thank you.
Probably, yes, ma'am.
Thank you. I thoroughly enjoyed the panel, and thank you so much, Himanshu sir. You like insight everything of IVF. I would like to add just two things. The technique of embryo transfer is also should not overlook. It looks very simple, but still a minor delicacy are there. And the second is it's not the pregnancy you test positive, it HCG positive is the success. It's the success is the carry on baby rate, so live birth rate. So followed by this IVF conception, the thorough care and the throughout the 9 months, the maternal and fetal well-being has to be managed well. So that would actually lead to the increase the pregnancy outcome, what we can see. But I truly enjoyed the panel, sir, and the board talk, Archana ma'am, and Jay Samin, sir. Thank you so much.
Thank you, Sejal. Thank you
It's
so
true.
much for
Whatever
sparing time.
get pregnancies you may get, ultimately the patient, unless they get a baby in their hands, it's of no use. And that is where,
Absolutely.
apart from many things, neonatology has also played a big, big role. You know, now we are saving babies of 24 and 26 weeks, which we could not save earlier. So, apart from the success rate improvement in IVF, the neonatology has complemented it so well. And so the patient should be delivered at the places where good neonatal care is available.
Absolutely, sir. Thank you.
Thank you so much, Sejal ma'am, for concluding in a very crisp and short manner. And I'm also thankful to the UNS peoples for crafting this whole webinar and helping us in forming the whole program. Thank you so much.
Right.
Can we stop, please? Yeah, we should end.
Dr.
Yeah.
Archana, madam, with your due permission, I would like to conclude the session with a few sentences, if you allow, ma'am. Hello, am I audible, Dr. Udri?
Yes. Yes, yes, you're quite audible.
Yeah. So, dear participants, thank you for being part of today for Fertilogix webinar series. It's an impactful academic initiative brought to you by Madhya Pradesh ISAR and in collaboration with UNSS Women's Health Business Unit. So your all presence and active participation actually made this event successful. And I must appreciate that across India, there are many doctors who are, flourishing their good comments, which I already shared in our comment box. And this was the platform which was enriched with logical based learning, clinical insights, and evidence discussions. So all thanks to incredible contribution from our all esteemed faculties. So a special note of thanks to Dr. Archana Madam for her insightful sessions and being, played a major role in this Fertilogix webinar. Dr. Jayesh Amin sir for sharing the actionable perspective on low MS. Dr. Himanshu Bavishi sir for masterfully moderating the panel. Dr. Sejal Madam for her clinical expertise and panel insights, and all our brilliant minds in panel, and our heartful appreciation to all chairpersons. Even we are honored to have our chief guest, Dr. Fagun Shah, Dr. C.B. Nagurishwar, and Dr. Alpej Gandhi. Their presence made like immense valuable to this academic experience to this event. So special thanks to Kalyani Madam also and Dr. Rudri for being in co-convener and convener and making this event flawlessly for the coordinating. And about UNS, definitely I must say we'll be there to contributing at every set in such kind of scientific and academic events in coming days to come. Right. So I sincerely apologize if I unintentionally miss any name acknowledging to it. So we sincerely thank you once again for your time, trust, and collaboration, madam. Thank you very much.
Thank you, everybody. And let's say bye and we meet again.
Thank you, Archana ma'am. Thank you so much,
Right.
ma'am.
Thank you. Thank you, everyone.
Thank you.
Have a
Bye-bye.
wonderful
See
day ahead.
you.
Thank
Thank
you.
you, everyone. Thank you.
Bye-bye. Nankishore, I'll request you to stop the sharing and close the event. Thank you.